Good morning, good afternoon, good evening to everyone joining in to this new normal of webinars. I'm Dr. Sadia Malik, and I would like to thank the organizers and especially Ferring International for giving me this opportunity to speak to this auspicious occasion of the Royal College Conference. I will be talking about the postpartum hemorrhage management and prevention today. And this is a topic which is very close to the heart of all of us as caregivers in this profession, and also that it represents the core of what we do day in and day out. But sadly, it still remains the number one cause of maternal death in both developed and resource poor countries. It is a major cause in the developed countries, and of course is the number one cause in all developed countries. And this is proven by the WHO statistics also, that nearly a quarter of all maternal deaths are associated with postpartum hemorrhage. Now, when we look at the new Embrace report, which I absolutely believe it is undoubtedly the best audit and research into the causes of maternal and newborn mortality, it describes us that still in the UK and Ireland, 14 women died due to obstetric hemorrhage in the last triennium. This represents about 0.63% of all maternities and is also slightly lower than the previous statistics in the 3 years before, but not statistically significant. So if you look at the numbers, this was between the triennium from 15 to 17, and now between 16 to 18, hemorrhage still sits here. But what I would like to bring your attention to is these statistics. The Embrace report from 2012-13 highlighted that a very high number, 74% of the women who actually survived the major obstetric hemorrhage said that there could be improvements done to the care which may have made a difference in the outcome. And if you look at the new report, it talks about the women who sadly died of hemorrhage. There were 14 women, and almost 80% of them, they report that improvements in care which may have made a difference in outcome. Now, this makes it very uncomfortable reading for caregivers who, like you and me, are in this profession. But what does it mean to the family of those women who died? Does improvement of care means that a mother could still have been with a baby, a wife could still have been with a husband, and a daughter could still be with her parents? Why is that? Why is that we are still having women dying of postpartum hemorrhage when we are experts in the antenatal causes of postpartum hemorrhage, in the intrapartum causes of postpartum hemorrhage, which we can use this for our prevention of this condition? We are confident about the etiology of these conditions, but still we are having these numbers for postpartum hemorrhage. Let's look into the prevention. We know that active management of third stage of labor lowers the maternal blood loss and reduces the risk of postpartum hemorrhage. Prophylactic uterotonic drugs should be offered routinely in the management of third stage in all women, as they reduce the risk of postpartum hemorrhage by about 60%. The oxytocic drugs should still be given with the anterior shoulder, and the delayed cord clamping should not be distracting us from doing so. Now, there are many drugs which are in the armory of the caregivers for prevention of postpartum hemorrhage. And many of these drugs have been given together, compared together in many research settings. We know that oxytocin, 10 international units by intramuscular injection, is still the drug of choice in the United Kingdom. And ergometrin and oxytocin can be given in the absence of hypertension. And we also know that neither carboprost nor misoprostol should be used for prevention, although they are very good for treatment. And in all these, where does carbitocin feature? We have been getting very good publications and research into carbitocin since many years. And we knew that this drug is good. And although we know that oxytocin is a best quality drug for prevention, but we know about the persistent quality problems in the low and middle income countries, that because it requires cold storage and transport, and this unfortunately is not present in the low resource countries. Heat-stable carbetocin is a promising alternative to oxytocin and can overcome the persistent problems with oxytocin quality, as it does not require a cold chain for storage and transport. But was it worth the extra expense? Further research was coming in and was always making sure that the results were telling us that carbetocin is not non-inferior, if not better. But it was really the landmark champion study. When it was published, it proved, and the results and the conclusion of the champion study was that heat-stable carbetocin was non-inferior to 10 international units of oxytocin for blood loss more than 500 mils or additional uterotonic use. Non-inferiority was not demonstrated by blood loss of more than a liter, and other secondary and safety outcomes were comparable between the two drugs. And it was because of the champion studies results that carbetocin was included as the uterotonic recommended by the WHO for the prevention of PPH. And in 2019, heat-stable carbetocin was included in the WHO essential medication list for uterotonics for the prevention of PPH. I would just like to say here that I have been trained in the United Kingdom. I've been working in the NHS since 2005, and I was consultant here for many years. But for the last 7 years, I've moved into the United Arab Emirates, and I've been working in Abu Dhabi in Cornish Hospital, which is a large tertiary hospital, large tertiary referral hospital for with more than 5,000 deliveries. And Cornish Hospital has a risk management process which is second to none. And what this risk management process noted that since 2016, the rate of massive postpartum hemorrhage was more than a liter. And this was above the benchmark set of 1.5% of all deliveries. In 2017, therefore, we made a new task force of a multidisciplinary team to reduce this incidence of postpartum hemorrhage. A critical appraisal was done for all the literature that I have presented to you, and it was decided that we will discontinue the use of symptometrin and we will start using carbetocin 100 microgram intramuscular for third stage of labor. And this was introduced in December 2017. I will be quick to add over here that carbetocin was not the only introduction that was done. A lot of work was done by this multidisciplinary team around including many processes, including making a pro forma for data capture of the vaginal deliveries and adjusted the form to provide optimal data. There were daily discussions at handover and safety briefings of all the cases of PPH to improve learning and management. A special traffic system scoring system was developed, which had this laminated and flashcards. And this assessed and reassessed the risk of postpartum hemorrhage at every admission for all antenatal patients and during delivery. A 360 degrees work was performed by this amazing team. And we noted that it was in December 2017 when we introduced the carbetocin 100 microgram IM. Then we looked at all the statistics, and when all the measures and medications were fully implemented, the number of patients with massive postpartum hemorrhage fell in the first quarter to 0 in 2018. Monitoring and evaluation was performed, and the PPH rates declined immediately, especially in the target vaginal birth area, and the percentage fell consistently to 1.3%. As you can see, we had 124 women with massive PPH in 2017, and it fell to 91 in 2020. And as you can see, this is our benchmark. We had a blip here, but it's 2019. We have been consistently going down in this graph, and so has been for 2020. I will again say that a lot of work was done in terms of communication, in terms of the multidisciplinary team to get these results in working to reduce the PPH rates. I would also like to highlight here the role of the co-pilot, or what is known as the scribe. And I'm very happy to see that even in the Embrace 2020 report, the value of the scribe in supporting the overview of the management was highlighted. We at Cornish Hospital have a special role of the scribe, and we call them the co-pilots. As you know, that whenever there is an emergency, we immediately come in as a team And one of the person identifies themselves as the team leader. And next to the team leader comes the scribe, who we call as the co-pilot. The scribe not only writes down the timings of the event, but also provides helpful prompts to the team leader so that the whole team works correctly, and whatever requests have been put, the blood actually comes, the drugs actually come, and the sequence of events of the process is maintained. So this has been a huge improvement, has really led to huge improvements in all our obstetric emergencies. And of course, the risk management process, right from training to skills drills to the end, where we debrief not only the patient, the husband, and the team involved. All these processes are also in place. Now, I would like to just ask the audience to kind of shift the background. I have discussed the research, I have discussed the publication, I have discussed how we translate the known evidence into reducing the postpartum hemorrhage. But I want to now highlight an area where you will see that unfortunately a woman is bleeding due to postpartum hemorrhage, or she is most likely to have a postpartum hemorrhage because of all our knowledge of high risk patients. But unfortunately, we cannot help them and we cannot use the evidence that I have just mentioned to you. And that is because of the area that this woman is coming from. The squalor, the poverty that is there. We can easily understand that the cold chain cannot be maintained. Oxytocin will not be available. And even if it is available, it will definitely be of poor quality. And other shocking things that are there, that women are being delivered in low resource settings. And not only that the oxytocin is not good enough, but the discussion has to start that veterinary oxytocin should not be used on humans. So in such frustrating situations, how do we go back to the evidence? How can we ask the evidence to help us to translate it to help reduce the postpartum hemorrhage? So if you look at the WHO guidelines, so WHO of course says that you need skilled health workers. If oxytocin is available, if the quality is not good, then you should use carbitocin. But as I have mentioned to you, if we don't have oxytocin, we don't have carbitocin, then we are left with trained community health workers and lay health workers, which can then administer misoprostol to reduce the postpartum hemorrhage. I have been working with an amazing charity, amalife.org, since 2005, and now recently a small local charity in Pakistan known Mother and Baby in Need. This was definitely a small local charity, but it really punched above its weight during the corona pandemic. And what it decided was that it will distribute the clean birthing kits, which included all the medications, including misoprostol, as advised by the WHO. And they would distribute it to the lengths and breadths of Pakistan. It had 7 items, all agreed by the WHO. And it only had this group of what the evidence wanted, that trained community health workers or lay health workers. So I would like to introduce you to all the heroines, as I call them, the frontline heroines, who we trained for the use of clean birthing kits along with misoprostol. And the good thing was that the training had started before Corona actually came into Pakistan. And we used low fidelity screening training. And also we used their own environment to train them how to use these clean birthing kits. And when the Corona pandemic came, we went to the houses and followed the SOPs and made sure that the training continued and the clean birthing kits were definitely available for these women. We also developed an app, a free application, which was available to download. And in this application, there were videos in the use of the clean birthing kits in the local languages. The women would come and they would download the application in the office, and then they would go back into the mountains and deserts. So they would have a helpful video to tell them if they had any other question. And along with the clean birthing kits, we had a side-by-side project, which we call the transport project. This was a clever idea in which we allowed the mothers to have phone numbers of the office. So every time if the mother was delivering at home and she had problems, either antenatally or postpartum hemorrhage, then she could just call in the office and a man with a van would be sent to her so he could take her to a place of care. Her only option was, without this transport facility, her option was to be strapped on a cot and to be taken on shoulders of men along these treacherous roads. And you know that the result of this is always not a happy ending. So we use these simple vans of the local areas and the local drivers who would then help us to transport these women. I'm sure that many people in the audience would be relating to this because there are many contraptions around the world that have been built in different areas according to the setting, which help to transport these laboring women to places of care. So in conclusion, I would like to say that carbetocin comes in two presentations. Both are heat-stable formulation. Injection carbetocin Ferring, which is a not-for-profit collaboration with WHO and MSD for mothers. It's public channel only for low and low middle income countries and currently registered in Switzerland, India, Tanzania, and Sierra Leone. And it is in the process of registration in the other low and middle income countries. As for injection Pabal or Duratocin, that is a commercial program and it is available in the high income countries in both the public and the private sector. I would like to really highlight the task force, the PPH task force, which worked at the Cornish Hospital and helped us to implement these figures. And I would also end by this amazing photograph, and this includes all the women that we helped to deliver, and they are now safe, and the babies are also safe, either by the means of the clean birthing kits or the transport that was sent to them. Each woman represents a story of how a good team in any setting can follow the evidence, can translate the evidence to help save mothers and babies' lives. I would be happy for any questions. Thank you very much for your attention. Thank you. Hello, everybody. Thank you very much for your attention and thank you very much for the questions. I've been reading them and I'll try to answer them. So the first question is, how do you manage situations where patients opt for physiological third stage and refuse uterotonics? I think this should be done in the antenatal period where every woman should have an informed choice. And if she still chooses to opt in after everything has been discussed, then we have to manage if the situation arrives at that time of postpartum hemorrhage, and we have to deal with that situation. But I really think that we have 9 months, if possible, for this counseling. The next question is about to suggest prophylactic B-lynch suture during cesarean section in high-risk patients. No, I would personally not put a prophylactic B-lynch because every action has its reaction and there can be risks to inserting a B-lynch also. There are other things that we can do if we think that this is high risk, which would be in terms of giving the uterotonics as per our guidelines. Next question is, what do you do when you encounter postpartum hemorrhage with no uterotonics? I will tie in with another question where people were asking about this is where we will use massage and of course the use of Foley's catheter, which we can use as a balloon tamponade, and we can also use condoms as a balloon to fill water in it and then train people how to use it as an effective mechanical tamponade. A role of the tranexamic acid in postpartum hemorrhage. Well, after the woman trial, we have absolutely no doubt in the use of tranexamic acid and how good it is and how it should be definitely used. But its role is more in the treatment and the management of postpartum hemorrhage and not in the prevention. Thank you, Ali, for your question. I'm glad that you got the gist that how much work goes into education, into the department, and not just one part of the postpartum hemorrhage. So you don't want me to repeat again how important it is to have a risk management process and training. But regarding carbetocin, I will say one thing, that in whichever setting you will work, the high risk setting, low risk setting, there are human factors. There are so many factors which can affect the cold chain maintenance of oxytocin. So that is why I honestly believe that wherever there is a risk that the efficacy of oxytocin will be affected because of lack of cold chain, I believe that carbetocin is the heat stable carbetocin is an excellent way of replacing oxytocin, so that even that small factor which is there, which can be there and give you oxytocin of decreased quality, should be taken away by using the heat stable carbetocin. So that's my take. What is the maximum recommended dose of carbetocin and misoprostol treatment of postpartum hemorrhage? So at the moment, carbetocin is used for prevention of postpartum hemorrhage. We are still doing research into the management. But regarding misoprostol, we give 800 per rectum, or sublingual also can be given. Again, how about tranexamic acid prophylactically prior to the cesarean section? Again, tranexamic acid should only be used if for management and not as a prophylaxis in our guidelines. What is your experience of using a Foley's catheter tamponade in a postpartum hemorrhage? Wherever Foley's catheter is the same as a Bactri balloon in many areas where Bactri balloon is being used. So if you want a mechanical way of reducing postpartum hemorrhage, you would insert a Bactri balloon. If you do not have that, then Foley's catheter is a good alternative of providing a mechanical way of clamping down the uterus and helping it contract. So those are the areas or the times when I would say that we should be using Foley's catheter. And I have got very good experience in that in the low resource setting, where we unfortunately don't even have the Foley's catheter. So we use a condom in replacement for the Foley's catheter to fill it with water, make a makeshift Foley's catheter, and use that for contract the uterus down. And we have been training most of the doctors and even the lay health workers into the use of a simple condom to convert it into actually a Foley's catheter or a Bactri balloon. The next question is a very nice presentation. Thank you very much. Can we give oxytocin and carbetocin simultaneously? Again, as we said that no, carbetocin at the moment is used for prevention of postpartum hemorrhage. If you feel that now you have used the drugs for prevention and now the patient is having postpartum hemorrhage, you will have to switch on to your protocol of management of postpartum bleeding, which would then be either oxytocin infusion, tranexamic acid, or the drip, or carboprost, and so on and so forth. So at the moment, for prevention, you can use either oxytocin or carbetocin. Is there any role of avoiding diclofenac in cases of postpartum hemorrhage due to aggravation of PPH by NSAIDs? Yes, absolutely. It is one of the guidelines that once somebody is having a bleeding, you shouldn't be giving them non-steroidal at all. Again, I think there is a lot of discussion about management, about prevention, and treatment of postpartum hemorrhage. So currently, the role of carbetocin has been confirmed, published for the prevention of postpartum hemorrhage. Do you experience many cases of retained placenta, especially in the resource areas? Any difference in management? Yes, sadly, this is one of the, I think, bigger causes. If it's not atony, then I would put retained placenta. And unfortunately, that is because of lack of training of the community midwives and the lay health workers regarding the controlled cord traction of a placenta. So and you know that it takes some years of training and lots of hands-on practice to really know how we would do a controlled contraction. And somebody who has not been trained is scared and frightened of the bleeding. That is what has been my experience as to why should somebody yank on a placenta, and especially somebody who is very, very experienced also. And that is because when there is a postpartum bleeding, a postpartum gush of blood due to atony, they feel, oh, it's just the placenta, and they yank on the placenta, and unfortunately, either a piece is retained or there is inversion of the uterus. So a lot of training needs to be done for every person who is going to conduct a delivery. Is anemia, definitely I really wanted to address this point. Is anemia a risk factor for postpartum hemorrhage? And if so, what is the cutoff even of the hemoglobin? You see, whichever setting you are working in, you would know that the level of anemia or the level of iron that you are working with at the start, you know, is where you have how much time that woman has before she just crashes. So unfortunately, if the baseline hemoglobin is 5 and 6 to start off with, then even less than 500 mils blood or up to 500 mils can immediately lead to cardiac arrest and so many problems in these women. So I think the biggest work again in prevention of postpartum hemorrhage is the correction of anemia, especially if you are working in areas where you have to transport the woman too far off area. Then that time that you will get would be from somebody with good iron stores and higher level of who would be able to withstand the journey without really starting from a hemoglobin of 5 or something like that. Um, what should you do if B-Lynch doesn't prevent postpartum hemorrhage in primary gravido patient with twin pregnancy? So you see, you should have a plan. With twin pregnancy already, you know that there would be a high chance of postpartum hemorrhage. So I think your uterotonics over here would play a great role, especially if given in time. Moving on to all the lists of uterotonics that you would have given, and tranexamic acid. And then, of course, if you are going to use the B-Lynch, you can, of course, then use it and keep going down. But with every postpartum lecture, I always say that resorting to an early hysterectomy would save lives. So it's great to talk about all these things that we can do for prevention and management, but a senior gynecologist would know when they're on that point where early hysterectomy will save lives. Does assessment of blood loss a great impediment to successful management of postpartum hemorrhage? I mean, you've really hit the nail on the head regarding assessment of blood loss. I would be the first person to say that many women have lost their lives just because we as a team were not on top of assessment of a blood loss. You know, we think we are very experienced and we've looked at it and so, oh, that's not 500. And that, so quantification of blood loss, if I can, you know, have one message to every team, that how sharp your quantification of blood loss would be, that is where you will see how quickly and effectively you will manage a postpartum hemorrhage and will prevent a postpartum hemorrhage even before your 500, if that is very, 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 very sharp. Can oxytocin be used in case? How soon after the use of carbetocin can oxytocin be used in case postpartum hemorrhage has ensued? Again, over here, I would like to highlight the word ongoing postpartum hemorrhage. So in our hospital, we give, if everything is fine, we give about 10 minutes during a cesarean section or otherwise to see. But you see, it is your assessment of an ongoing bleeding where you would know that now I'm in the zone of an ongoing postpartum hemorrhage, and you would come in and you can always start your other medication. Does balloon tamponade have a role in situations where surgery might be delayed? Absolutely. I think balloon tamponade does come in that sense, where at that time where you would use that as your first line, and then of course you would use your other methods. But of course, if there's heavy bleeding, then you would be continuing to think of other things. Thank you very much. I think this is my cue to wrap up. Thank you so much for the questions. Thank you very much. Thank you.